Hello, good morning. It's 11:30 in the morning. We're talking about Saturday here for the session on diabetic retinopathy. And we don't have to tell again and again that diabetes is an important problem. Retinopathy is sickly of diabetes. I think everybody knows this, so we'll much add you. We'll Shubha Prasad, my co-chair from Moorfields, London, and me will conduct the session. We have 7 speakers lined up for the meeting. The 7th one, Professor Neil Bressler, will be joined online because he couldn't travel for his personal reasons. So we'll begin with Professor Praveen Basis from AIMS RP Center, Dr. RP Center, Delhi, who will talk on global epidemic of diabetic retinopathy. Praveen did a wonderful work actually in India, doing a larger survey of most Indian states to find out the status of both DM and DR. So nobody can be more eligible than Praveen talking about the DR status in India and global. Praveen, up to you.
Thank you so much, sir. In fact, I am really grateful to sir for giving me an opportunity to present this topic. I'll be talking about global epidemiology of diabetic retinopathy and with specific emphasis on India. In fact, if we specifically talk about diabetes mellitus, so currently the prevalence of diabetes is considered around 10.5% globally. That means we are nearly 537 million diabetic globally. And 44.7% of these remain undiagnosed. Beside this, nearly equal number, 10.6%, 541 million, are pre-diabetic with impaired glucose tolerance. And diabetes-related death globally are nearly 6.7. We see the prevalence is higher in higher age group, up to 79. But when we see the projection by IDF, from the current number of 537 million, we go to 643 million 2030. And by 2045, the number is estimated to be around 783 million. And 3 out of 4 adults with diabetes, they live in low and middle income countries. If you see the projections of diabetes by 2045, the maximum number is in Africa. It will increase to 134% by the year 2045. And after that, it is basically in Asian countries and Middle East countries. Specifically, if talk about India, as per the India App study, the prevalence of diabetes, national prevalence is 11.4%, and the total number around 101 million diabetics. In fact, I remember 10 years ago, we were saying that by the year 2030, we'll reach to 80 million, but we are already 101 million. That is very high number in India. And beside this, much more number, nearly 15.3% are pre-diabetic, which account to 136 million. For diabetic retinopathy, I'm quoting this recent published paper, the systematic review on meta-analysis, which was published in 2021. The diabetic retinopathy prevalence globally is taken as 22.27% among the diabetics, which is responsible for nearly 103 million diabetic retinopathy cases. The vision-threatening DR is 6.17%, and macular edema is 4.07%. The estimates for 2045, so diabetic retinopathy will be 160 million, vision-threatening DR will be 44 million, and CSME will be around 28 million. Again, if we talk about the prevalence, the current prevalence is highest in African countries, is around 35.9%, and in North American and Caribbean countries, 33.3%. Maybe the number may be highest in Western Pacific and Asian region. The prevalence is highest in African and North American regions, and lowest prevalence is in South and Central America. The prevalence of diabetic retinopathy in India, in fact, we have national survey figures, which was conducted from 2015 to 19. And as per this survey, prevalence of DR is 16.9%, and prevalence of STDR is 3.6%. We have another smart study, which shows the 12.5% lower prevalence, but STDR is slightly higher, it is 4%. That means in nearly 101 million population in India with diabetes, nearly 4 million people, they have vision-threatening or sight-threatening diabetic retinopathy. Then another systematic review conducted by T.P. Das sir, and we have all the major studies in this systematic review. And as per this, the prevalence of diabetic retinopathy is around 16.1% in the country. Whereas if we talk about DR in overall population, it is 1.63%. So 16.3% among the diabetics and 1.63% overall population is the prevalence of diabetic retinopathy. They have done various subgroup analysis, and this shows there is some increase in rural population, though the overall burden is higher in urban population, but there is narrowing of gap between urban and rural age groups. The sight-threatening DR as per this meta-analysis is 4.5%, slightly higher side, and diabetic macular edema is 2.1%. So compared to other countries globally, it is lower. So I will speak about the national survey, which we conducted from 2015 to 19. The prevalence of diabetes in 50+ age group was 11.83%, and nearly 1/3 of diabetes was unknown in that population. If you see age and gender-wise distribution, it was slightly higher among males, but almost equal, the prevalence of diabetic retinopathy. It was less in 50 to 59 age group, but higher in older age group. But probably the most important finding which we get is 90%, 89.9% of diabetic patients in India, they are not getting their retina examined. So you can understand what the status of actually coverage of diabetic retinopathy patient being seen by the eye ophthalmologist. The glycemic control is also poor. Near 60% of patients, they have poor glycemic control. Just 40% they have good glycemic control. If we see in various districts, the prevalence of diabetes and also diabetic retinopathy is much higher in southern India compared to northern Indian states. Again, the STDR also is ranging from 0% to 6.2% is again higher in South Indian states. But when we talk about blindness and MSVI due to DR, the proportion is much less. Out of the total blindness, just 1.2% of blindness is attributed to diabetic retinopathy. And if we see MSVI, it is just 0.7% of MSVI in India is attributed to diabetic retinopathy. If we talk about the various risk factors for diabetic retinopathy, probably the most important risk factors are the duration of diabetes, poor control of diabetes, pregnancy, hypertension, nephropathy, and a combination of factors like hyperlipidemia, smoking, cataract surgery, obesity, and anemia. Among them, the modifiable factors are blood glucose, blood pressure, blood lipids, body mass index, and smoking. What I want to show here that higher the duration of diabetes, higher the chances of having diabetic retinopathy in the country. Just to summarize, as far as diabetes is concerned, the total number is 537 million, and it's 1/3 of number is in the Western Pacific region. Expected number is estimated as 783 million by the 2045, and maximum increase is expected in African countries. India has already crossed 100 million diabetics. The prevalence of diabetic retinopathy globally is 22.3%, and vision-threatening DR is 6.2%. Highest prevalence currently is in Africa. DR in India is 16.9%. And duration of diabetes and uncontrolled diabetes are the risk factors, major risk factors for diabetic retinopathy. Thank you very much. Thank you.
Professor Bashish told that he had to go to another meeting, but I had two things. One, if you had any question now immediately to ask him, or if you can come back after your next presentation, please.
Yes, sir. Yes.
Then please go do that and come back to the
Sure.
chair. Thank you so much.
Thank you.
So we have the next speaker, Warapon, talking on managing diabetic macular edema in 2025.
Thank you. When we look at our diabetic macular edema patients in our clinic, I think we can simply classify them into 4 types based on their visual acuity, their clinical presentation, and OCT findings. So the first type is those who presented because of decreased vision, and you can see significant degree of diabetic macular edema So the first type is called center-involved DME with visual impairment. The second type, the patient had no visual symptoms. The visions remain very good, but you can see significant degree of macular edema on OCT. This one is called center-involved DME with very good visual acuity. The third type, the patient had no symptoms, central subfield thickness still within the normal limits, but you can see some abnormalities on OCT. This one is called non-center-involved DME. And the last one is significant macular edema correspond to the traction or significant epiretinal membrane. This one is DME caused by traction. How to manage this patient? For DME with traction, I think everyone agree that we should go on with vitrectomy. For non-center-involved DME, we have no anti-VEGF RCT at this time, perhaps because the patient had no visual symptoms. So we have only ET direct study, which is the only level 1 evidence that we have. So we should perform focal grid laser if the patient met CSME criteria. For center-involved DME with very good visual acuity, we learned from the RCR protocol V that we can start with observation and then follow them every 3 or 4 months, and then give rescuing anti-VEGF when the vision dropped. For the first group of DME patients, we have several level 1 evidence, including protocol T, that show the highest efficacy of aflibercept over ranibizumab and bevacizumab, and recently protocol AC in 2022 that we can actually start with bevacizumab first for at least 3 loadings injections, and after 12 weeks onwards, we can switch to aflibercept without compromising vision in the long run. What about the new management in 2025? I think for these 3 types of DME, it remains the same. The only new information is for DME type 1, center-involved DME with visual impairment, which we have the new anti-VEGF options here in 2025, faricimab and aflibercept 8 mg. So what is the role of these new anti-VEGF agents for visual outcomes and treatment burden when treating DME, and whether these new agents show any superiority over the old drug, aflibercept 2 mg? Yosemite and Wright is the phase 3 RCT comparing the efficacy and safety of faricimab to aflibercept 2 mg, and the patients were randomized into 3 arms. 2-year results show that the mean vision gain over 2 years were comparable between eyes receiving faricimab and aflibercept. And if you look carefully, you can see at the number that faricimab group actually have a little numerically higher than mean vision gain of those who receive aflibercept 2 mg. Thus, this means that faricimab group or faricimab had superiority in terms of visual outcome comparing to aflibercept 2 mg. Actually, from the study design, I don't think we can conclude that, because they had different number of loading injections. Faricimab Q8 weeks received 6 loading injections, while aflibercept Q8 week received only 5 loading injections. So even they receive Q8 weeks until the end of year 1, the treatment visits is different because they start with different number of loading injections. So at the end of year 1, where they assess their primary endpoint, which is the mean visual acuity change from baseline, average from 3 last visits, week 48, 52, and 56. And if you think that the best time to measure the visual acuity change is within 4 weeks after the last injection, those who are assigned to receive faricimab will have 2 injections within 4 weeks before the assessment period, comparing to only 1 aflibercept 2 mg injection within the assessment period. So according to this study design, I don't think it not allow fair comparison between the 2 drugs. So we cannot conclude that faricimab is superior to aflibercept 2 mg from this data. Now let's move to aflibercept 2 mg. So photon study is the RCT comparing the efficacy of aflibercept 8 mg versus 2 mg. And again, by the end of 2 years, we can see that aflibercept 8 mg show comparable visual acuity results to aflibercept 2 mg. But if you look at the green line, you can see that it was below the blue line, which is 2 mg, since after the first loading injections. So I don't think this data show that aflibercept 8 mg shows superior visual acuity comparing to 2 mg. But the advantage is the fewer number of injections. So it means that the strong durability results in less number of injections, but the visual outcome is comparable to the 2 mg. And in terms of durability of faricimab and aflibercept, actually from the data, it shows strong durability. A majority of participants in both trials can extend treatment intervals beyond 12 weeks, but no evidence of stronger durability comparing to aflibercept 2 mg because aflibercept 2 mg never given the opportunity to be extended beyond 8 weeks. Another issue in 2025, I think right now the treatment regimen that everyone prefer for neovascular AMD and also DME is treat and extend. But treat and extend in AMD may be a little different from treat and extend in DME. To apply treat and extend in AMD, we typically give monthly loading injections until the retina dry, and then we start extend the treatment interval. But for DME, it is much more difficult to dry the retina. After loading injections, even in protocol T, aflibercept arm showed that after 6 monthly loading aflibercept injection, 32% of them still have persistent edema. So if the patients still have persistent edema, when will you start extend the injection intervals? So if you look at the clinical trials that apply treat and extend in DME, there are several trials here, and you can see the extension criteria is quite various. Some of them use both visual acuity change, some of them use only OCT. For OCT, some of them use the central subfield thickness change within 10%, and then they start extend. Some of them use the cut point of 300 microns. We have no consensus here, so I think we have to stay tuned for the standardized criteria in the future. So in conclusion, in 2025, we have new anti-VEGF molecules to treat eyes with center-involved DME with visual impairment. Both faricimab and aflibercept 8 mg show great efficacy to improve visual acuity and also strong durability to treat DME patients. Regarding the treat and extend regimen for DME, however, it is very important to develop a standardized criteria which is not yet established. But right now, you can apply the criteria that you prefer and practical to treat DME patients in your practice. Thank you very much.
Thank you. Would you like to join with us? Want to join here? Thank you. Now call upon Professor Paulo Antonio Silva talking about the ultra-wide field imaging for diabetic retinopathy. Remember the days when we had a 30-degree camera and ETDRS talked about the 7-field where the disc center, macula center, up and down, sides-wise. Then it moved to 45-degree or 60-degree. Today it has ultra-wide field. While most low resource countries cannot manage it, cannot procure it, but then they're not denying that this is useful for certain situations, if not all.
So,
yeah, Dr. Silva.
So good morning. So it's a pleasure to be here and to be able to share some of our work highlighting how ultra-wide field imaging is changing how we diagnose diabetic retinal disease. So these are my financial disclosures. So telemedicine programs for diabetic retinal disease rely on remotely acquired images, a centralized evaluation of these images, and findings communicated to the remote site. Data from the UK has shown that with current diabetes and eye treatments combined with telemedicine, this may reduce the incidence of diabetes blindness by as much as 95%. So ungradable images impact telemedicine programs. Ungradable images can vary from 10 to up to 56%. So it's critical to identify methods to decrease ungradable images. Ultra-wide field imaging has decreased the ungradable rate from 10 to less than 3% per patient in our program in Boston. It also identified twofold more patients with DR and referable DR without the need to dilate pupils. Potentially, a combined ultra-wide field and OCT imaging device is an ideal system for many diabetic retinopathy screening programs. It allows the imaging to be acquired in the same sitting, improving patient and healthcare logistics, particularly in eyes with visually threatening center-involved macular edema, as the OCT integration increased the detection of true cases of CIDME by over 7-fold and reduced the rate of false negative cases by over 66%. So the current diabetic retinopathy severity scales are designed to predict progression to PDR. However, estimates are broad, and each severity level may not represent a group with similar long-term risk. So we have described what's termed as predominantly peripheral lesions that may be present in up to 50% of eyes. This increases DR severity in about 9 to 15% of eyes and can be identified with ultra-wide field color or FA imaging. This data, along with data of others, has supported the development and performance of Protocol AA. So DRCR Protocol AA was a prospective longitudinal study to understand whether ultra-wide field imaging improves our ability to evaluate diabetic retinopathy and predict progression. So this is an eye wherein the areas with PPL are highlighted by the white arrowheads. Focusing on the superior temporal quadrant, you can see these lesions occur outside the ETDRS fields. With the ultra-wide field FA overlay, you can see these lesions occur at the boundary of the perfused and non-perfused retina. So the primary outcome of Protocol AA was the proportion of eyes experiencing DRSS worsening by 2 or more steps from baseline or receipt of treatment through 4 years. It's important to emphasize that the outcomes were assessed within the ETDRS fields using ultra-wide field images. So this graph shows disease worsening in PPL, showing no difference in the rates of progression. However, when looking at eyes with more severe DR levels, the presence of PPL on color was associated with a higher risk for progression. This graph shows DR worsening and FA identified on FA, PPL identified on FA. And you can see when PPL by FA was present, the risk for DR progression was much higher. And this was consistent across all DR severity subgroups. So in the AA cohort, eyes with PPL by FA had a 1.7-fold greater risk of disease worsening over 4 years. This was consistently present across all DR severity subgroups. Among eyes with NPDR, the presence of PPL identified using ultra-wide field FA imaging appears to be a marker for increased risk for disease worsening that is not detectable using standard ETDRS photography or ultra-wide field color imaging alone. So fluorescein angiography of the ETDRS area has been studied in detail. However, only 2 30-degree FA fields were evaluated in the ETDRS. Data from Protocol AA has shown that with increasing DR severity, you see increasing retinal non-perfusion. However, baseline presence of PPL on color was not associated significantly with increased non-perfusion. However, PPL on FA was significantly associated with a 50% increase in retinal non-perfusion. Similarly, eyes with the highest non-perfusion were at the highest risk for developing progression over 4 years. So worse DR severity was associated with the increasing non-perfusion. Non-perfusion identified on the ultra-wide field FA in these diabetic eyes was located primarily in the mid and far parietal periphery that are not visualized by standard ETDRS FA imaging. And the presence of PPL identified on FA has been shown to be associated with increasing retinal non-perfusion. We also evaluated the effect of DR lesion location and severity. So these series of graphs show disease worsening by lesion severity location. So you can see in both ultra-wide field color and FA, irregardless of the lesion location, the risk for retinopathy worsening was similar. DR lesions identified on ultra-wide field color and FA images, whether predominantly within, predominantly outside, or uniformly distributed, have similar risks for DR worsening. So we also looked at whether these peripheral lesions, which increase the severity level, predict long-term progression. So this is an eye with mild NPDR on the masked ultra-wide field color image. You can see HMAs less than 2A, but on the unmasked ultra-wide field FA, you can see significantly more lesions, and with HMAs greater than 2A and IRMAs greater than 8A out in the retinal periphery. So these series of slides showed disease worsening by the presence of more severe lesions in the periphery. And when these lesions in the periphery are present, the risk for DR worsening is increased. So this suggests that failing to identify eyes that only have posterior lesions will lead to an underestimation of risk of DR worsening, and that identification of lesions throughout the entire retina is critically important to accurately stratify the risk of progression over time. So we also looked at the agreement between what we see on the FA and the color in the assessment of DRSS. As I mentioned earlier, with these more peripheral lesions when present on the FA, the risk for worsening is increased. So this is a cross-tabulation of the unmasked ultra-wide field DR severity and the masked ultra-wide field color. And you can see 62% more severe DR on the unmasked ultra-wide field images, suggesting that you really see much more disease. This is even more striking when you're looking at mild to moderate NPDR, with 80% more severe DR on the angiogram. This suggests that the ultra-wide field FA is more sensitive in detecting early microvascular changes and peripheral lesions that may be overlooked on the ultra-wide field color. So what does that mean? How does this impact our care? So this graph shows disease worsening by the difference in baseline DRSS on ultra-wide field FA and color. So you can see when the eye had more severe DR on the ultra-wide field image, ultra-wide field FA image, the risk for worsening is much higher. So compared to ultra-wide field color, ultra-wide field FA identifies more disease in over 50% of images. This is most evident in early levels of retinopathy. Eyes with worse baseline DR lesions on FA compared to color images had higher rates of disease worsening over 4 years. And eyes with worse baseline DRSS on the ultra-wide field FA compared to color images had higher rates of disease worsening over 4 years. So to conclude, these results suggest that features on the ultra-wide field color and ultra-wide field FA images may provide additional prognostic value in determining the risk for DRSS worsening. The accurate classification of overall disease severity and quantification of risk of disease progression could be improved by accounting for lesions to include those predominantly outside the ETDRS fields. So thank you. Before I end, I'd like to invite everyone later this year to the APVRS in Manila, in the Philippines.
Okay, so we'll move on to the next speaker, Divya Rao, AI monitoring based on handheld fundus camera images. So you're just moving on from ultra-wide camera to literally a handheld fundus camera. Divya.
Hello everyone, thank you so much for joining us today, and thank you to APO, AIOC, as well as the chairs, Dr. Shobha and Dr. T.P. Das, for giving an opportunity to speak today. And today I'll be focusing on AI-based screening using handheld fundus camera images. And here are my financial disclosures. Some of it is relevant to the talk that I'll be giving today. As Dr. Praveen has already alluded, diabetic retinopathy is going to rise. We are at 103 million today, and this is going to exponentially increase to 160 million by 2045. The Smart India study has shown that the prevalence of diabetic retinopathy is at 12.5%, with close to 3 to 4 million people aged over 40 years have VTDR, vision-threatening DR. And what is alarming is a significant proportion of these patients with diabetes were unaware of their status, and this cohort had a higher prevalence of diabetic retinopathy and VTDR. And this poses a significant economic burden on the individual and on the country, and also on the quality of life. However, a programmatic intervention of this can be successful, and the English National Diabetic Retinopathy Screening Program has shown that diabetic retinopathy is no longer the leading cause of blindness in the working age group, and over 80% of the people with diabetes who were offered screening completed the testing in 2019 and 20. So now we do have diabetic retinopathy screening guidelines in India as well, thanks to the consensus statement between the AIOS and VRSI. They've covered a lot of aspects in terms of screening models, annual screening for those with diabetes and more frequent for those with high risk, the type of fundus cameras to be used, minimum camera specifications, as well as stating that a single field image that includes the disc and macula should to be sufficient. Also covered things like targeted or stage mydriasis to improve gradability of images, and also made recommendations regarding teleophthalmology or use of AI software, and to maintain an NCD registry for these patients. There's also a recommendation to decentralize diabetic retinopathy screening to physicians who are the first point of contact of those with diabetes, and also made recommendations regarding teleophthalmology and AI-based screening for physicians as well, also ensuring a care loop closure to the ophthalmologist to referral services. The utility of non-mydriatic fundus cameras and in diabetic retinopathy screening has also been alluded in these guidelines, and they have looked at handheld fundus cameras as well as smartphone-based fundus cameras. And the advantages being that these camera systems are universally accessible and can be affordable and cost-effective screening solutions, while acknowledging the limitations that some of these systems can definitely have reduced image quality in the elderly, especially with cataracts and small pupils. In India, Kerala has really taken a leap forward in diabetic retinopathy screening, thanks to the initial pilot that was done at the Nayanamritam project. This was done in collaboration with the Moorfields Eye Hospital as well as the government of Kerala, where they used smartphone-based imaging and teleophthalmic grading. And there was a clinical care pathway that was implemented as well for those detected with referable disease. And the outcomes of the project were that they saw 17% of those to be detected with diabetic retinopathy, 8% of those were referred, and alarmingly, 99% of them were unaware that they had diabetic retinopathy, and a majority of them were actually in the working age group. And they showed that this could be a cost-effective screening. Screening could be cost-effective because at 100 rupees, they were able to screen and treat patients when normalized across the population. And this allowed the screening to be expanded from 16 to 200 centers, and looking to add more centers this year. And now there's also reimbursement under ABDMPMJY policy. So the key learnings were that diabetic retinopathy screening is cost-effective in India, and teleophthalmology-based screenings were not scalable as there were a lot of dependency on reading centers and training of graders. There was a need to pivot towards AI-based screening with immediacy of results, and the nurses could actually educate the patients on need for referral and further management, and this could potentially increase the uptake on treatment. And they also made a recommendation that a stage mydriasis was necessary to improve the gradability of images to at least 70%. Now, there are established global diabetic retinopathy screening programs that have included AI as part of their initiatives. Like in Scotland, AI has actually replaced the level 1 graders. In Thailand, they're using Google ADA, which is a cloud-based system. And in Singapore, they're also using the Selena, all of them showing that this can be promising and reducing the burden of diabetic retinopathy. In the US, there is the handheld camera system, which is also approved for use for diabetic retinopathy screening, along with AI showing good results. Now, what about in India? So through the Ornate project, they used a deep learning model for grading of diabetic retinopathy that was developed on mydriatic retinal images and applied it on non-mydriatic images in community settings. Though the results were not very promising, they had very key findings that offline AI was necessary without requiring internet or cloud infrastructure, and that referable DR recommendations, if through AI was possible while being trained on non-mydriatic images, could make it far more accurate. And immediacy of results was necessary, and deep learning models that can actually classify the gradability of images on these systems was essential for the end user. So in the Indian context, there is a smartphone-based fundus camera with integrated offline AI for diabetic retinopathy screening now that can expand the scope of diabetic retinopathy screening in India. And this system, you can do a stage mydriasis where once first you can capture non-mydriatic images, and if the images are insufficient, then you can dilate as needed, and immediately it gives a feedback on the quality of the images. And with a click of a button, you can get a recommendation for referable diabetic retinopathy that is more than moderate severity, and this is nearly instantaneous, and you can also review these results remotely through teleophthalmology. This algorithm has been extensively validated in real-world settings against consensus grading of diabetic retinopathy through consensus grading for diabetic retinopathy through graders, and has received global regulatory approvals both in Europe and Singapore, and is also the first approved algorithm in India. So it's not about studies alone. This algorithm is also being implemented in real-world settings. In Kerala, now they've already adopted the system, and it's expanding from 50 to 210 centers. The Arvind Eye Care system, the SHOF system, has also adopted this, and through their hub and spoke models, the referral pathway has also been taken care of. And beyond India, it's been used in several settings like in Romania, the Dominican Republic, as well as several settings in Africa, in Zambia, and Tanzania as well. And this has allowed us to screen close to 500,000 people for retinal conditions over the past 1 year, and we've detected close to 48,000 cases of diabetic retinopathy. Now, this has moved beyond DR to referable glaucoma and referable AMD as well. And what we look at as future direction is that with this single retinal image, can you make screening more cost-effective by combining other disease conditions beyond diabetic retinopathy like glaucoma and AMD, and in the future systemic disease as well. And given the massive population that we have of diabetes, can we look at pre-screening methods with, say, point-of-care tests with cystatin that has shown promise? A lot of work that has been done by Dr. Shobha and Dr. Rajiv Raman. Can we look at predictive algorithms for personalized follow-up to extend the screening intervals in those with lower risk? And as also the previous speaker spoke, can we be looking in the future at portable SLO-based wide-field imaging systems for smaller pupils in the elderly to reduce the amount of ungradability and pick up more diabetic retinopathy? So in summary, India is definitely moving forward. There are indigenously developed diabetic retinopathy algorithms, and the first approved in India is the one that we spoke about as well. This works completely on the edge, not requiring cloud inferencing, and is integrated within the camera system on the smartphone-based camera system with real-time gradability feedback. And there have been multiple prospective real-world clinical validations on this. Now we have established guidelines for screening for diabetic retinopathy. Though the adoption across states has been sparse, but with Kerala leading the way, we are on the right path. And with reimbursement models through the ABD and PMJY, this can boost the adoption rates. Thank you so much for your patient listening.
Thank you, Divya. Wonderful. Could you have a seat here with us? Is Lalit here? Lalit Verma here? I didn't spot him, but in case I'm aware. If not, we'll move to the next talk, and when he comes, we'll bring him back. This is Professor Suvasi Prasad from Moorfields. We'll talk about the possibility of PDR treatment with laser and anti-VEGF. Remember the days when DRS suggested that should do only a pan-retinal photocoagulation for patients confirmed with the proliferative retinopathy. It had its own merit that it was easier to give and compliance was a problem. The compliance was not an issue. But anti-VEGF certainly has its own merits of preserving the visual field, but requires a little more expensive and more compliance. So let us see if we can combine the two or give separately. Shobha, for you.
Thank you, Dr. TP, and good morning, everyone. So as we said, I'll go through the pros and cons of PRP, anti-VEGF, or both. So these are my disclosures. So for proliferative retinopathy today, I will be only covering NVE, NVD, and pre-retinal hemorrhage and vitreous hemorrhage, not obscuring the fundus. So these are the ones where these three type of treatments are applicable. I'm not covering vitrectomy today. So as Dr. TP just mentioned, PRP is the standard treatment for PDR, no doubt about it. It is a very well-established therapy for over 4 decades. There's significant number of changes in technology, all for the better, to reduce pain, to increase the number of spot sizes. So the Pascal laser, or the pan-retinal photocoagulation multi-spot laser, is very commonly used. At least in the UK, this is standard of care. I would say there is actually, with this, of course, there's less pain, easier to do, and faster. But the main problem is we tend not to give enough number of laser burns to the eyes, and therefore there is a risk of worsening of retinopathy if the retina is not covered completely. So coming to pros and cons of pan-retinal photocoagulation, the gold standard for treatment of PDR. Of course, the pros are it is a very well-established therapy. Field loss may not all be due to PRP, and I'll cover that later. It's, of course, as Dr. TP said, it's low cost, and therefore patients are more compliant. And also we must think diabetic retinopathy is a global disease, so this PRP is, of course, makes it globally applicable for all countries to have, and it needs less number of follow-up visits compared to anti-VEGF therapy. Of course, the con is the insufficient laser treatment. In protocol INT, Susan Bressler had published that if you compare modern day multifocal or multi-spot laser versus single spot laser, what she reported was a worsening of PDR complications, more TRD, more NVI, etc. And the reasoning behind that was that because we apply less number of lasers. So yes, multi-spot is good, but we have to ensure that the area is completely covered. Field loss is, of course, a problem with PRP, but with these type of newer lasers, that is less likely. There was a paper from Bradford in UK that showed that field loss is not a significant problem these days. There's, of course, increased risk of macular edema, other visual function losses, and, of course, laser causes irreversible damage to the retina. So there are loads of confusion about whether targeted laser is better than the usual scatter laser we do for PDR. There are few publications on this, none are long-term, and so far there is no difference in visual acuity, visual field, pain level, prognosis, or adverse events when comparing targeted laser to non-perfusion areas versus scatter PRP. So the conclusion to date is targeted laser is not needed, especially when you initiate treatment. Now, when we continue treatment and we do not know where to apply more laser, then perhaps doing a fluorescein and identifying areas of non-perfusion would be useful. Now, that's all about PRP. Now, when we compare anti-VEGF with PRP, of course, the protocol S is the study that gave us the most amount of data on this. So it was prompt PRP versus ranibizumab plus deferred PRP in PDR study. It was a generalizable study, so there are several advantages of reading up protocol S for if one wants to do anti-VEGF therapy. It included PDR patients with and without macular edema, and it has a 2-year primary outcome followed by a 5-year follow-up. It had a large sample size, and vision criteria is something we see in clinic. It was very broad, 24 letters or better. Treatment regimen was practical. The PRP arm allowed completing PRP in 1 to 3 sessions, and that's what we do clinically as well. Ranibizumab was allowed in both arms if the patient had DMO, and supplemental PRP was also allowed in both arms. So a really real-life situation. So what did we learn from the Protocol S 2-year results? The retention rate was very high in the clinical trial. Visual acuity in the first year, ranibizumab arm did better than the PRP arm, although in the second year they balanced out. The field loss was of course worse in the PRP arm, but the regression rate of new vessels were very similar but edged better on the ranibizumab side. And then the DRSS2 level improvement was in about 50% of the patients. Ranibizumab showed improvement in DRSS level, and only 6% in the ranibizumab arm required supplemental PRP in the trial, while 45% required repeat PRP in the trial. Now, development of DMO, 35% required ranibizumab in the PRP arm at baseline, and another 18% required it over the 2 years. So these are the lessons we have learned if we are to do monotherapy. It is 2-year results, sort of okay, but we must then move on to the 5-year results. So this is the 5-year results, and here you can see that the visual acuity is similar in the 2 arms. So it's plus 2.5 in the ranibizumab arm if you had DME at baseline, and plus 3.2 if there was no DME at baseline. And you can see in the prompt PRP arm, it was very similar. Also, in the ranibizumab arm, they had to have 19.4 injections versus PRP arm where it needed only 5.4 injections. Of course, anti-VEGF in PDR over the 5 years did reduce the rate of vitrectomy and low incidence of diabetic macular edema, reduce risk of traction, and it's cost effective if the patient had PDR plus DMO. However, the protocol 5-year results did show a 40% dropout rate, especially in the minor ethnic group. So that's a very important point with long lapses between clinic visits. So now when you look at the 240 patients eyes that were left in the study, you can see the regression pattern is very similar between the ranibizumab monotherapy and the PRP arm. The DRSS improvement was similar to the 2-year results in the ranibizumab arm. Supplemental laser was again more in the PRP arm. Again, it only shows us that because we have to keep doing until we get complete PRP. And of course, all the other complications of PDR was less in the ranibizumab arm. So in conclusion, what you get from here is that by 5 years, there was not much change between visual acuity outcomes between the PRP arm and the ranibizumab arm. I said that I would come back to the visual field. So here, the blue line is the visual field loss you will get with PRP. And the yellow line is the one that you will get in ranibizumab arm censored after PRP. So you will see that ranibizumab arm also loses visual field over the 5 years. So when you say visual field loss, even for anti-VEGF patients, we need to consent them and say that their visual field loss will decline, and this probably is due to the continuing capillary non-perfusion that we see with anti-VEGF therapy. So then goes the Clarity study. This is a study we did in the UK. Here we compared aflibercept versus pan-retinal photocoagulation, and we did not include patients with macular edema, and it was a 52-week study. Here we found that aflibercept was superior to pan-retinal photocoagulation at week 52. What are the secondary outcomes? Here we found, again, very similar results to Protocol S. We found very higher amount of new vessel regression, more number of patients became mild or moderate NPDR, and there were less incident macular edema, less traction, less need for vitrectomy, and of course, very few injections were required after the 3 loading doses. An average of 1.4 injection was given over the 52 weeks. So all these are positive results. This is the type of appearance you will give. I'm sure all of you have seen that with anti-VEGF therapy. You see a complete regression of the new vessels. Looks very beautiful, as if we have reversed cosmetically a very good retina. However, we did a lot of post-hoc analysis on the Clarity study, and it showed despite the improvement in DRSS, there is no change or worsening of capillary non-perfusion, i.e. anti-VEGF does not have an effect on capillary non-perfusion. The venous beading also remain unchanged. New vessel discs are more resistant to anti-VEGF therapy than NVE, and it is not cost effective if you are treating patients with PDR without macular edema. This is the field loss that I mentioned. So the last trial that I want to mention is the Proteus study, which was a trial looking at a combination of ranibizumab plus PRP versus PRP. And here ranibizumab and PRP were given together at baseline and every other visit. So in a year, it's a small study, but there was a mean of 4 injections and 3 supplemental PRP after completion. And they also found a regression of NV, the visual acuity was better in the combination arm. So the question is, if we are giving anti-VEGF therapy, should we be giving PRP alongside? The PRIDE trial was such trial where they compared ranibizumab versus PDR versus combination. Again, a very small trial, 106 patients across the 3 groups. Here again, PRP was given in repeat sessions. Combination was first ranibizumab and then second month combo. Again, same results, new vessel regression, more patients became NPDR in the ranibizumab arms, but recurrence was high. So in conclusion, yes, anti-VEGF does give better visual acuity and structural outcomes. However, the recurrence rate is high. We have to have long-term meticulous follow-up, which is very unlikely in our people with diabetes who have multiple comorbidities. So we have to be very careful not to put patients on monotherapy if you think they will not come back to us. It is cost-effective if anti-VEGF is given alongside in patients with PDR plus DMO. The UK practice is to give PRP if patients present only with PDR, and to combine PDR and PRP and anti-VEGF therapy if patients present with both PDR plus anti-VEGF. If a patient develops anti-VEGF after laser treatment, we still give them anti-VEGF plus PRP if required. Thank you very much.
Thank you, Shobha. Equally important that understand that laser or anti-VEGF will not take away your diabetes. So as long as diabetes is there, the risk is there of returning your new vessels or macular edema. Important to control diabetes biochemically and by other parameters. In India, also important to control anemia and hyperlipidemia. So patients should be informed that just because you are doing a laser or an injection or the combination, you have to still keep controlling your diabetes and then returning at least yearly or half yearly to follow up to the physician or the ophthalmologist. We have the next is actually a virtual presentation by Professor Neil Bressler, role of anti-VEGF therapy to prevent diabetic eye disease. So Neil, are you ready there? Looks like, no, we are anywhere at least 4.5 minutes ahead of time. We do not have Lalit Verma, then I have some professional commitment I have to run away. But while I am not here, or Neil and Lalit have not joined, I will request Shobha to conduct all this discussion with all the presentations.
I'm Neil Bressler, and I'm happy to present the role of anti-VEGF therapy to prevent diabetic eye disease. These are my financial and other disclosures. We know that anti-VEGF is an effective treatment for eyes that have center-involved diabetic macular edema with vision loss, or for proliferative diabetic retinopathy, or even to be used in eyes that have both of these at the same time. An obvious question then is, can anti-VEGF therapy prevent these vision-threatening complications in eyes that are at high risk of developing center-involved DME with vision loss or proliferative diabetic retinopathy? And if anti-VEGF can prevent these vision-threatening complications, is there a visual acuity benefit by 4 years associated with the prevention of these complications? Take this patient, for example, with visual acuity of 20/20. The OCT shows some slight thickening based on population norms, but there are numerous areas of intraretinal microvascular abnormalities consistent with very severe non-proliferative diabetic retinopathy. Over the next 4 years, this patient has a 20% chance of developing diabetic macular edema with visual acuity loss. In addition, this patient has a 50% chance of developing proliferative diabetic retinopathy over the next 4 years, and almost a 60% chance of developing either one of these over the next 4 years. The DRCR Retina Network in Protocol W looked at the effect of anti-VEGF therapy compared with a sham treatment to try to prevent the development of vision-threatening complications, including diabetic macular edema with vision loss, or proliferative diabetic retinopathy, or both. Eyes were randomly assigned to one of these two approaches, and the primary outcome at 4 years was reducing the risk of developing proliferative retinopathy or diabetic macular edema with vision loss. And if this risk was reduced, was there a visual acuity benefit to this preventative treatment? Throughout the study, all eyes were treated promptly if they either developed DME with vision loss or if they developed high-risk proliferative retinopathy. They were treated with aflibercept per the DRCR Retina Network guidelines that are used for DME or proliferative retinopathy. The treatment was given at baseline and then monthly at months 1 and 2, and then in 2 months at month 4, and then every 4 months through month 24. Then, beyond month 24, injections were given if the retinopathy was worse than mild non-proliferative retinopathy. There's a difference between endpoint and treatment in this trial. In terms of managing proliferative retinopathy, the endpoint was developing any one of these features of proliferative diabetic retinopathy, but treatment only was applied if there was high-risk proliferative diabetic retinopathy as defined by the diabetic retinopathy study, or if there was vitreous hemorrhage from proliferative retinopathy. Once initiated, the treatment, as I said, followed the Protocol S algorithm in the DRCR Retina Network. For managing DME, DME with vision loss was defined as an increase of 10% or more in the central subfield thickness from baseline with visual acuity loss, defined either as 2 or more lines, 10 or more letters from one visit to the next, or 5 to 9 letter loss, 1 to 2 lines of visual acuity loss at 2 consecutive visits to be certain that such loss was real. If this did develop, then treatment was initiated per the DRCR Retina Network Protocol T algorithm for treating diabetic macular edema. There were approximately 400 eyes randomly assigned either to the preventative treatment with aflibercept or a sham treatment with prompt initiation of aflibercept treatment if either DME with vision loss or proliferative diabetic retinopathy developed. What were the anatomic results? It can be seen obviously here that the sham group had about a 60% chance over 4 years of developing either proliferative retinopathy or DME with vision loss, and given preventative treatment, aflibercept reduced this substantially to 34%. And this was true whether we looked just at the outcome of proliferative diabetic retinopathy, a 50% chance over 4 years with sham, 28% chance with aflibercept. Or if we looked at the outcome of center-involved diabetic macular edema with visual acuity loss, even though these eyes did not have center-involved DME with vision loss at baseline, having severe non-proliferative retinopathy indicates a high risk of having the macula become diseased in this way in just 4 years. 20% of the sham eyes developed DME with vision loss, and even the eyes that were given preventative therapy, still 10% of those with aflibercept developed DME with vision loss. However, even though there was a substantial reduction of these anatomic severe vision-threatening complications, there was absolutely no benefit for the visual acuity. As long as you promptly initiate aflibercept instead of giving it as a preventative, you can get the same preservation of visual acuity with sham and prompt intervention for either high-risk proliferative retinopathy or DME with vision loss, as you would get if you gave preventative therapy, and if either of those complications developed, you jumped in with additional therapy. This was true no matter how you looked at the visual acuity outcomes at 4 years. 20/40 or better, 20/20 or better, 2 or more lines of vision loss from baseline, 3 or more lines of vision loss from baseline. No matter how you looked at it, the aflibercept prompt preventative treatment was no better, not superior, not safer than just observation, which was sham in this case, and prompt intervention. So what do these mean for people who have very severe or severe non-proliferative retinopathy? The Protocol W conclusions were at 4 years, treatment of non-proliferative retinopathy with aflibercept versus sham treatment resulted in a statistically significant and substantial anatomic improvement, but no improvement in visual acuity. So aflibercept, as a preventative strategy is used in this trial, may not be generally warranted for most patients with non-proliferative retinopathy without center-involved DME. What about our patient? The patient was 20/20, had these high risks of developing these anatomic complications, but as long as we jump in with aflibercept if they develop, the vision outcome would be the same as preventative therapy. Indeed, this patient, 18 months later, developed high-risk proliferative retinopathy and thickening consistent with diabetic macular edema with some vision loss, and so aflibercept rescue therapy was initiated. 24 through 48 months, this patient remains with no evidence of proliferative retinopathy after starting this therapy and remains with 20/20 visual acuity, even though we observed until high-risk proliferative retinopathy developed, or we would have observed until DME with vision loss develops. Conclusion, evidence-based medicine always considers the patient's values, their unique preferences, their concerns, their expectations. What if the fellow eye in this patient had severe non-proliferative retinopathy that was observed, developed a non-clearing vitreous hemorrhage, and needed vitrectomy? Maybe preventative prophylactic therapy might be considered with that individual patient. The results I told you were based on the averages in a trial. That doesn't mean it's unsafe to give preventative therapy in such a case. What if the fellow eye had severe non-proliferative retinopathy and rapidly progressive posterior subcapsular cataract, underwent cataract surgery and developed substantial edema? Maybe prophylactic anti-VEGF might be given before that cataract goes on to cataract surgery. But functional outcomes typically should trump anatomic outcomes, as we will hear throughout treatments of macular disease. As a guideline, not a rule, aflibercept or even a port delivery system with ranibizumab as a preventative strategy, as used in the DRCR Protocol W or Pavilion trial, generally may not be warranted for patients with non-proliferative retinopathy in the absence of center-involved DME with vision loss. And with that, I thank you for letting me share it with our colleagues in India today.
Thank you, Neil. So we have lost a few speakers, but we will have some discussion. So my first question is to you, Virupon. So we discussed, I mean, you gave a very good talk on diabetic macular edema in 2025 and how we manage it. One point you mentioned was that you would do laser treatment for non-center involving diabetic macular edema because if they are clinically significant. Protocol V showed us that even with center involving macular edema with mild vision loss, we can just go ahead and observe them. So in the UK especially, we tend to observe these patients more than treat them. What is your view? Is it because you fear that patients don't attend that you want to do the laser treatment, or is it because laser was also found to be useful? So what's your point there?
Yeah, so I just mentioned that only ETDRS is the level 1 evidence that explore the treatment outcomes in these groups of patients. So far, if you want level 1 evidence in this group of patients who have non-center involved DME, you have only ETDRS. And if you want to follow their results, they recommend laser treatment to preserve vision, to prevent moderate visual loss, right? But in my real practice, so I would do the laser treatment if they show focal edema.
Okay.
Yeah, because I think
so you restrict.
in that group of patients, it showed good results. But if it showed diffuse edema, then I would rather observe.
Okay, so my next question is, you showed that in protocol T, 32% of the patients had persistent edema. So if you see such a patient in clinic today, how would you manage that patient? Yeah.
So after 6 loading injections, if I start aflibercept already, and then I will consider whether I laser will play role. If they have focal edema, I will add laser. If they have no focal edema, then I will start to treat and extend.
Treat and extend?
Yes.
No role for steroids?
No, not in my clinic, yeah.
So you don't use steroid at all as a second line?
Yeah, so I use Osidex in some cases, but
Yeah,
the
that's what I meant.
limitations is
Yeah.
the financial restriction of the patient.
Oh, I see.
Yeah.
Okay. So for us, after 6 injections as well, or after 5 in case it's aflibercept 2 milligram, we switch them to dexamethasone if there has persistent edema. Most of the time, the macula will definitely dry up, but the visual acuity doesn't improve. So you have a point in just observing the patients as well. And we are all, very prone to treat these patients. We don't want to see the fluid, and therefore we try to treat them.
And do you use any OCT biomarkers to select which one should use steroid, which one should not?
Yeah, there is a lot of data on that, but it's so conflicting. And I haven't noticed anything like the papers suggest that we can subretinal detachment, or if you see a lot of hyperrefractive foci, then these patients are better off with steroids. We definitely did the same trial, same study, and we did not find any difference. So I still doubt whether there is any role for biomarkers in managing, in thinking of which option to go for. I would definitely start patients with anti-VEGF if they are visually impaired due to diabetic macular edema.
So you mentioned that after 6 injections, if the patient have persistent edema, you give steroid,
Osidex.
right? Osidex.
Yeah.
And what about in the next 3 or 4 months?
So we review the patients after 3 to 4 months, and if the fluid recurs, of course, then you know that Osidex also is not working. In that case, the patient goes into a treat and extend, as you mentioned.
With anti-VEGF, right?
With anti-VEGF. But if most of the time they respond, the fluid responds very well, but the visual acuity doesn't improve. So we could, in most cases, there are some where the visual acuity will improve alongside drying of the macula. In those patients, we can give a repeat Osidex. Yeah, but that's lesser and lesser. We just published a paper. We showed that the average number of Osidex injection after anti-VEGF with persistent macular edema is 1. So which means that most of us then go back to giving them anti-VEGF on a treat and extend regimen.
So I have a question. So how about biosimilars? So not only
Yeah.
just biosimilars for ranibizumab, but biosimilars for bevacizumab. So we've done it in the Philippines wherein we use these biosimilars per bevacizumab, and the cost for the injections is markedly reduced to less than $5 per injection. So can you share some of anybody?
So is biosimilar bevacizumab as cheap as
It's
aliquoted?
extremely cheap. But
Ye-
basically it's about $5 per injection.
For the biosimilar as well?
Yeah. So if it's
Oh, I see.
compounded, not the so in the US they have a biosimilar which is purchased, which is not cost effective in my opinion. But when you compound a bevacizumab biosimilar,
Oh, you compound
down
biosimilars.
a
Okay.
bevacizumab
Yeah.
biosimilar, so that drops the cost down substantially.
Okay. So we don't have, I mean, we don't do that. But on the other hand, Protocol T has shown us that, comparing the three drugs, aflibercept has an edge over the other two. But if the patient has mild visual acuity impairment, then you can use any, right? So first line, you can use bevacizumab and then move over to a more potent one.
So even for eyes with visually significant, you can start with bevacizumab and
Correct.
switch over to aflibercept.
Correct. And also with newer agents, like 8 milligram as well as faricimab, you have an even bigger choice to move across. You did suggest and you did stress it is increased durability for the arms, but not stronger durability when compared to 2 milligrams, because we do not have a comparative like-for-like trial. How would you start treatment? If you have aflibercept 2 milligram biosimilar, 8 milligram aflibercept and faricimab, based on your experience rather than the trial, how would you manage your patients?
So back to real life, right? So in Thailand, now we have new regulations that every patient must start with biosimilar Avastin.
Oh, so
Yeah.
same.
Yeah, for at least 3 doses. And if they did not show good response, then we have an option to switch either aflibercept 2 milligram or faricimab. But the 8 milligram now is not, is approved, but not everyone cannot reimburse yet. Yeah.
All right. So do you aliquot your biosimilars Avastin as well? So
The pharmacy.
So
Okay.
it's as large as
Yeah.
a bevacizumab
Alright.
vial. So it's not
Yeah.
one for intraocular use, it's one that they use for cancer chemotherapy.
yeah, but it is a biosimilar.
Exactly.
Yeah.
Oh, so it is cheaper. That's
Much,
interesting.
much cheaper.
Yeah. So Divya, I just want to ask you a few questions. So we had Paulo just describing very beautifully about the use of ultra-wide field and the understanding we have received from that. But in real world, we are going by a handheld, two-field, AI-integrated image. What is your take of it? I mean, globally, we
Yeah.
cannot afford ultra-wide
That's right.
field.
So I've worked on both. So I've worked on both the handheld AI device with Tunde and also with Lloyd and the folks at Jocelyn really done a lot of work on ultra-wide field imaging. So I think it's not a one-size-fits-all. So there's a high resource and a low resource settings, and we need multiple approaches to be able to attract and be able to capture the entire diabetes population. So it's not a one-size-fits-all.
It's complementary, right?
That's right.
So
I
you want
I
to
think he absolutely said it right, because from a screening context, we right now don't have affordable wide field imaging systems that are SLO based. So it has to be contextually driven, and in low resource settings, if we are able to go into the field with portable systems and be able to detect these conditions, I think moving forward, if we are able to get to a point where these systems, the wide field imaging systems, can be more affordable, then that would be a way moving forward. It's basically contextually driven.
Paulo, with your ultra-wide field understanding of all the disease mechanisms, we usually do only two-field in screening. Is there any biomarkers in the two-field from your understanding of ultra-wide and PPL lesions, etc.? Is there something in the center that can help us so one is more severe than the other?
Yeah, so that's something that we need to find out.
Okay.
So retinal vessel caliber may be a potential tool. And if we get AI metrics, so we've done AI to be able to predict progression over time and seen that the AI algorithm looks at specific areas in the retina that may be potentially predictive of future progression, something that clinically you may not be able to see readily, but with AI algorithms, you can potentially see these.
Yeah, yeah.
Yeah, there's been
So-
some work on that even in India. Dr.
Yeah.
Rajiv Raman's group actually has looked at whether looking at the posterior pole, but trying to predict that based
Peripheral,
on
yeah.
peripheral lesions. I think an AI-based approach based on what we can't see right now, but through biomarkers, we would eventually be able to figure out.
Yeah, the key set is being able to have a data set that encompasses both. You need
Exactly.
to have both the ultra-wide field data as well as the two-field or whatever risk factor analysis you want to look at. And the data set from AA, and also a lot of your work may potentially provide this.
And it should be, the AI should be developed on the films and images that we do in real world and not a clinical trial, because you can't replicate. And you had a question? Yeah. Can't hear. Yeah, better.
Right. Well, thanks for an excellent talk as usual. So my practice for CSMO with normal vision is to do a focal laser. But did you imply that we could observe them as well?
Yeah, in the UK, we observe more than we laser. For this non-center involving macular edema based on the protocol V study, because that shows whether you laser or you apply anti-VEGF or you observe, the outcome is the same, right? So about 17%
Yeah,
progressed.
but the ETDR study showed it reduces the risk by 50% over
Yeah.
a few years. So there's a conflict in the result of these two trials. In my mind, laser is relatively, not say 100% safe, but very safe, and it reduces
No,
the
there
risk.
is absolutely no right or wrong there. You can, of course, apply laser, especially if you are sure that patient is the one-off and he will not come back. I will definitely do laser on those patients. The sursinates,
Yes.
the focals. The grid, I would definitely wait for and initiate anti-VEGF. The ones that are eligible for grid, I don't think they work well with lasers.
So what's your personal recommendation? Well, I'm always a bit tentative that which patient will move the eye at the wrong time, we don't know. So if there is a way to observe them, then that would be my preferred option. So
As long as the patient comes back, right? We don't want, you see, when the patient comes back and the visual acuity is still good, but the macular center involving has become thick, you can start on anti-VEGF. But if it's a patient who is non-center involving at present and comes back only a year later with a vision drop and center involving macular edema, you will regret not doing the laser. If it's surcinate, focal microaneurysms, treat them. Yeah.
So what's your personal advice? When a patient will ask invariably, what do you advise? So what
Our practice, we see our patients much more regularly, right? So it depends on your health system and how much you know the patient. If the patient comes back regularly, I would observe them, because now we have a choice of waiting because protocol V showed us that.
All right, thank you.
OCT screening.
Can I ask a question here? Sorry to intervene.
Oh, yes. Yeah.
In India, we find that we are, quite often we are using Paginax, brolucizumab. So what is your take on that?
It's challenging because I have never used brolucizumab, so I can't say, but, and the speaker today, Dr. Lalit Verma didn't turn up to give that talk, so I don't know whether anyone wants to give their personal experience of brolucizumab. I clearly haven't used it, and I wouldn't be able to comment. Any of you?
Very limited use.
I think India uses it a lot, so if one of you want to talk about it, would be great.
So how's your experience in India?
Hello. In many of the situations, like in AMD and PCV, we have found that brolucizumab is working. Even in CRVO, macular edema, I've tried. My personal experience is very positive. Like in intractable cases, it is working very effectively. And the duration of the interval time also is increasing. Like the recurrence is much delayed in case of, but that risk is what we are worried about. So we follow the patient very closely and explain to the patient that if there's any problem, to immediately report.
Correct, yeah.
So in my opinion on that, I think right now we have several options of anti-VEGF. I mean, in addition to Paginax, we have aflibercept 2 milligram, faricimab, or even the 8 milligram. And because of the complications that you mentioned, we know that in DME patient, even for those who have persistent edema for a very long time, the vision did not that bad. So I think in my preference, I would not choose the anti-VEGF that will risk for the vision-threatening complications. Yeah.
So would you do it as second line if your aflibercept doesn't, show
So
persistent
I would
fluid?
rather switch to the other anti-VEGF
Otherwise.
agent. Yeah.
So it will be the third or a fourth line for you.
Yeah.
Okay. Anybody else has any experience on brolucizumab? Yeah. I have one question for Divya. So clearly, it's actually such a good progress in our lives with AI integrated DR screening without the use of online cloud or anything like that. So you see a patient, the device tells the patient, the technician whether it's gradable or not gradable, and also give you a referral or non-referral diagnosis. I mean, this gives you added advantage of advocacy, educating the patients to then turn up to a hospital. What do you think? Do you think it has achieved more than the usual cloud-based AI systems? I think yours is cloud-based, right?
So cloud-based and as well as something that we've done in-house that we can run locally on a machine. But I think those are all, they're all great. They all have pros and cons.
Yeah. Well, what about your experience? I mean,
in terms of performance, I think all algorithms, there are multiple algorithms right now, all of them are doing really well. I think, like we spoke last, it's more contextually driven. In India, we realized that a lot, in the community settings, it's very difficult to have reliable internet connectivity. So it was very important for us to bring the algorithms offline. So right from the time of development, we chose architectures that could be integrated on the device itself, leveraging on the iPhone processor, so that they could nearly instantly give results. And also, cloud infrastructure here in India means that you need to make heavy investments to host the algorithms on the cloud. And with our interactions with the government, it seems like that is going to be a barrier going forward, because that in itself is a huge investment for the government. So I think bringing the models offline definitely has its advantages. But in terms of performance, I think all algorithms, there are multiple there doing very well.
So the advantage is probably you can give the result to the patient immediately.
Yes.
And
I think that's also a very important point that you made, because most of the times you're going to see the patient just once. And they are not going to wait for a teleophthalmology grading. Even if it's a 10-minute delay, we have many times seen patients just walking away. So the instancy in results help in two ways: to immediately educate the patients on next steps in management. So I think that can actually help in better adherence to the next steps as well.
So in the Nainamardam project, where we had this referral rates into the ophthalmology center, only a quarter of the patients attended the referrals. So with that as the benchmark, have you done any studies to show that actually integrating AI and giving the results immediately improves adherence?
I think that's the next step we are looking at now, because we really want to see, screening is one thing, but at the end of the day, we really want to see that referral is increased so that these patients actually receive the management they're supposed to. And now in the second phase of the project, there are two aspects that we're looking at, is in terms of how can we improve the referral rates, and also look at bringing in AI into the cost effectiveness of the entire solution.
Yeah, it was great to see that you also screen for glaucoma now and for AMD. And actually, it's almost like screening for eye health, right? Because if you can't grade them, then they have cataract.
That's correct.
And then if you grade them and you see a cupped disc, that's glaucoma. and then you have retinopathy. So probably more and more studies on this area may allow national eye health screening.
Yes, absolutely, because I think that's where we should be headed at the end of the day, looking at how we can provide as much of comprehensive information to the patient as possible. And if that single retinal image can screen for multiple conditions and hopefully even beyond the eye going forward, I think we'll be providing much better care to patients at the end of the day.
You have a question?
Yeah. I have a question where during the presentation you've mentioned that anti-VEGFs may not have any effect on ocular perfusion. Okay, and thereby they may not have any impact on visual fields. So over a period of time, do you think that other agents need to be added to for maintaining the ocular perfusion? Or, for example, I was more correlating it with anti-glaucoma drugs. Like, for example, the topical CAIs, they improve the ocular perfusion. So do you think that there could be a role of topical CAI along with anti-VEGFs in these proliferative diabetic macular edema conditions to improve ocular perfusions?
It's a good question. So carbonic anhydrase inhibitors usually improve perfusion of the optic disc vascularization. It is not the retina. So that particular drug is very unlikely to improve retinal non-perfusion. There are a few clinical trials on semaphorin A, which probably is an angiogenic agent in terms of naturally improving the size of the FAS. But it's only going into a phase 2 trial now. I do not know of any other agents that improve retinal non-perfusion to date. We had a lot of hope on anti-VEGF because DRSS severity scale improved, but the fluorescein angiography did not. It showed deterioration. Okay, the deterioration was not as bad as if the patient didn't have anything. But that doesn't mean we could use that. And I think Dr. Bressler just mentioned, right? There's no point using that as a preventive treatment either. So yeah, that's where we are.
Thank you.
Thank you. Any other questions? Any questions from the panel? Yeah. Okay, thank you very much, everyone.